right, last but not the least, we've got my dear co-faculty here, Dr. Igor Immerman. Dr. Immerman is a UCSF faculty in orthopedics. He's an associate professor and an upper extremity surgeon. He and I have done a bunch of cases together on 3D guided implants and instruments, mainly instruments, not implants. And he's really taken the lead on this. And it was interesting to see in his CV that he's visited the Ilizarov Institute in Kurgan many years ago as a fellow after his residency, and then also spent some time in Moscow, which was the competing institute at the time, at the Central Institute for Traumatology and Orthopedics. So Igor, please take it away. He's going to talk about 3D patient-specific guides for upper extremity reconstruction. Thank you.
Thank you very much, Sanjeev. I'm honored to have a chance to present. I'm really humbled by the talks I heard, especially about, doing these complicated operations without, without having fluoroscopy. And so someday I wish I could do that as well. So can you guys, can everyone see my screen?
Yeah.
Okay.
That's all good.
Great. Perfect. So, those are my disclosures, nothing relevant to the talk. So I'm sort of speaking about something that's totally opposite of what some of the previous talks were about, which is maximum resource intensiveness, I suppose. Although I imagine there's a world where perhaps a 3D printer is available, but we don't have some of the intraoperative imaging or some of the other expensive technology. So this is not completely irrelevant and perhaps will be interesting to everyone here. So the problem is that, and I'm mostly an upper extremity surgeon, so that's what I'll talk about. And, upper extremity deformity, it's complicated. And, it can be post-traumatic, at least in my practice primarily. And this is, examples like cubitus varus or forearm malunion, missed Montegio fractures are common. And, a lot of it also is just even simple Jerry-J instability after distal radius malunited fracture. And the literature is pretty clear that a lot of this deformity is multiplanar. It's pretty easy to assess two-dimensional deformity, but the rotation in the axial plane in the forearm is very tough. And traditionally, we would correct this using plane X-ray or two-dimensional planning. You have multiple X-ray views. You can template the osteotomy preoperatively, and then confirm the plan using various angle measurements, using X-rays in the operating room. You have to kind of use the contralateral limb for your template. It can be difficult to account for rotational deformity. I think this method has a steep learning curve, as I think others have touched on. It is a long time to really figure out how to do this well. The results can be hard to reproduce, and it requires improvisation in the OR, which can be fun, but also can be very stressful. So here's an example. This is a 16-year-old boy who has osteogenesis imperfecta, and he's 6 years after a forearm fracture that was treated without surgery. And he comes in with good pronation, but very limited supination. He's unable to, do a lot of his daily tasks. He wants to play guitar. He has difficulty with that. So this is clearly a multiplanar deformity. It's a challenging case. You have both ulnar and radius involved. There's bowing, there's angulation, which probably can be templated fairly well two-dimensionally. But there's also rotation. So you have to rely on bony landmarks, which, vary from individual to individual, actually, especially in the radius. You have to use the contralateral side. So there's ways to do this, but as you can imagine, there's a lot of fiddle factor. But this could be improved, and we have the technology today to do that. We can maximize our pre-op planning so that we can then take the guesswork out of the OR. Maybe that could lead to shorter operative time, although maybe we're spending more time preoperatively, but you can produce a more reliably reproducible result. And I think in some cases can be better function in the end. And so what we can do is we can use three-dimensional computer-aided planning. You can really use that to visualize all planes of deformity. Can even in the forearm can model rotation actually and see what's happening, what's blocking the rotation. You can use 3D printing to then produce bone models to help guide surgery. Or you can even create custom osteotomy guides and fixation guides, and in some cases, even custom implants to do the correction. And it is possible actually to do this fully in-house. So you do need certain things. You have to have a CT scanner, software. So there's some open source software that can be used, but there's also commercial software that you have to buy that allows you to do the planning. 3D printer and the materials to print. And then you have to develop some technical expertise to do it. Alternatively, this can be outsourced to a commercial company. I mean, that's what I know. That's how we do it here. Although we do have also an in-house lab that can create models. But primarily for the surgeries I'm going to show examples of, we outsource to a third-party company. So we get a CT scan on a patient. We send the CT scan to the company. And then the surgeon has multiple meetings, or usually multiple, sometimes one meeting with an engineer via the web, where you kind of design the surgery essentially, and then the final product, whether it's the models of the bone or it's the guides, can be shipped to the hospital for the operation. So here's that example. Here's the forearm malunion. Here's the radius, and you can see there's angulation and also rotational difference. And here is sort of a simulation of rotation that kind of shows bony impingement and limited supination that the patient gets. And we can, design the osteotomy. So we're fixing the correction to align to the contralateral limb. We can design the guides. So we kind of pick what hardware we're going to use, and basically we pre-drill. We plan that we're going to pre-drill for the hardware to realign the bone. And here we're designing the guides to do that. You can really see the rotational correction built in on the radius. And then here's the guide designed for the cuts. So this is a guide for the osteotomy. And then kind of you can simulate what it's going to look like. And then the final product you can see there on the x-rays. And here's his result where, we changed the kind of the rotational arc a little bit, but overall it's a pretty good functional result. And he's been very happy with that. It's not exactly super easy to do. There are definitely pitfalls here. This type of planning can't account for soft tissue. So I may plan a really ideal correction, but it may not be achievable because of soft tissue limitations, or we don't necessarily get the rotation we want, especially in chronic situations. In the upper extremity, we have a chance to shorten the limb because, if there's a bit of a difference in length, most patients don't notice. I imagine the lower extremity, it's a little bit, you have to really maintain length for proper gait. I really have to think about anatomy and the approach that's possible. Sometimes we'll talk with an engineer and the cut will be perfect to correct the alignment, but it's in a place that's difficult to access and difficult to plate, for example. And then we also have to think about growth. So in pediatric patients, timing is key. The CT scan sort of expires after a little bit because the patient may continue to grow. And so whatever models we design don't fit very well. So we have to do this relatively expediently, especially in kids. Here's another example. This is a 16-year-old with a distal humerus malunion. You can see the cubitus varus very obviously, but it's hard to appreciate the rotation. So when we scanned them and did the analysis, you can see there's a 50-degree malrotation compared to his contralateral side. But, so to do this, obviously there's different ways, but this technique allows us to really make it anatomic and actually make it look nice on x-rays. So we designed a double osteotomy, taking out wedges. We shortened him a little bit, but we're able to correct the rotation. Here's the guides that we used and designed for the drilling and cutting. Here's a view intraoperatively of the guide being positioned, and then the plate on the lateral side, and then the additional plate on the medial side, just to give extra support. Interestingly, I mean, there was talk before about C-arm. Usually, a lot of this operation can be done without the C-arm because all the analysis imaging is done before the operation. And here's his final result. So there's a lot of case series here on this technique, reporting good outcomes, reporting precise correction. I only found one really randomized trial comparing the techniques. So this is a trial that randomized patients with distal radius malunions. These are simple malunions, extra-articular corrections, so fairly straightforward to do with or without this technique. And They saw a slight improvement trend in the 3D planning group, but it wasn't anything that reached statistical significance. The operative time and pre-op planning time, interestingly, was very similar, which I found to be surprising personally, but that's the data. But they did have significantly reduced fluoroscopy time in the 3D guided osteotomy group, which makes sense because a lot of it, you don't need to do any x-rays really until the very end to confirm that the fixation is appropriate. So in the end, is it better? Well, I see a lot of advantages for me at least. It shifts a lot of the work to the pre-op setting. It minimizes guesswork in surgery. It really improves the precision reproducibility of correction, but it is costly. Not everyone can have access to this, and there is a learning curve. Those are some of the disadvantages. Does it lead to improved clinical outcomes? Perhaps yes, I think so, but we don't really have the data to prove that as of yet. Thank you.